Good evening to everyone present here with us today. This is Shreyan from IGCP, today's moderator. I would like to welcome all the viewers who have joined our platform for better exchange of knowledge that is going to be shared by your keynote speaker, Doctor, for today's session. With much pleasure and honor, I would like to welcome a very renowned Professor Dr. Nishant Kumar. Sir is MBBS, DA, DNB, MNA, MS, Professor at the Department of Physiology at Lady Harding Medical College and Associate Hospital. With the help of Sir and his wonderful insight, we will be taking a close look on today's topic, which is non obstetric surgery in pregnancy. Now, without any further delay, I would like to welcome Sir at our forum and would like to hand over the session to him. Over to you, Sir.
Good evening, everyone. So, just give me a minute for technicalities while I share my screen. Yeah. Uh, yep, I think you should be seeing my screen now.
Yes, sir.
Right.
Your screen is visible to us.
Able? So, okay. Okay, thank you. So, today's topic is non obstetric surgery in pregnancy. Now, whenever we talk of pregnancy, we have to talk of the physiological considerations. Why? Because pregnancy is not a disease, it's a physiological condition, but yes, it is different. So, are there any concerns? Why are we so worried about surgery in pregnancy? So, we'll talk about the concerns that we have. How do we manage these women perioperatively? And we'll consider some special cases such as laparoscopy, cardiac surgeries, and exit procedure in brief. Okay. So the incidence of non-obstetric surgery, that means that a pregnant woman coming for any other surgery ranges between 0.22 to 2%. So not a huge number, but yes, they do present. And the most common indications are trauma, acute abdomen, mainly due to cholecystectomy, cholecystitis, or appendicitis, coming for cholecystectomy or appendicectomy, or an underlying malignancy. So these are the most common conditions for which surgeries are carried out in pregnancy. Now, this is absolutely true. The pregnant patient can have any disease that any other woman can have except sterility. So this is just the tip of the iceberg, but a woman can present for any surgery during pregnancy, be it ear-related, be it throat-related, be it any other condition which any other normal woman can. So it is not an exhaustive list. Any disease under the world, any surgery under the world can be done in a pregnant woman. So how is pregnancy different from the normal physiological state? Talking of CVS, we know that the cardiac output increases up to 50%. The uterine perfusion increases by 10% of cardiac output. The systemic vascular resistance, peripheral vascular resistance decreases. So that means that the uterine perfusion is not auto-regulated. We have to maintain a map, otherwise the baby will be at a disadvantage. And because of the decrease in SVR, any drug, it is not only spinal or spinal anesthesia or epidural anesthesia, but in the general anesthesia also hypertension is much more common in these patients. And because of the growing uterus, there's something called as the aortic cable compression, which the uterus compresses on the vena cava, reduces the preload to the heart, and can cause hypertension in these patients. So a left lateral tilt is mandated in these patients. Coming to the respiratory system, there's an increase in minute ventilation, which results in respiratory alkalosis. So whenever we are giving general anesthesia, the inhalation induction is faster. And it is also important because the pregnant state is adapted to a low PaCO2. Anything above 40 or more than that PaCO2 level is hypercarbia for these patients. Naturally, because of the growing uterus and the changes, there's expiratory reserve volume, residual volume, and FRC all are decreased, thus increasing the closing capacity, making these patients more at risk of hypoxemia in the supine and Trendelenburg positions. Also, there's increased PQ mismatch, increased oxygen consumption because the baby is there, upward displacement of the diaphragm, and there is mucosal edema because of the effect of the progesterone and water retention, which makes that they are easy. The mucosa is much more friable. There's edema of the larynx, so laryngoscopy is difficult, and we can easily cause trauma to the airway and cause life-threatening hemorrhage even. So these are the concerns in the respiratory physiology. In the CNS, because of the increased intra-abdominal pressure, the epidural main engorgement, bloody tap is much more common. Decreased epidural space volume. So the local anesthetic spread is much more, and also these patients require a lower dose of local anesthetic because of the increased sensitivity, and also they have an increased sensitivity to opioids and sedatives because of the increased progesterone effect. When we talk of the hematological system, the red cell volume increases by 30%, plasma volume by 50%. So even though the red cell volume increases, the plasma volume increases much more, causing dilution anemia, more chances of heart failure, increased coagulation factors, so thromboembolic complications, deviative prophylaxis is a must in these patients. The albumin is decreased and colloid oncotic osmotic pressure is also decreased, leading to edema, decreased protein binding of the drugs, so that the drugs that are required are available more in the free forms. So accordingly, the dosages have to be adjusted. GI, we know there's an increased intragastric pressure, delayed bowel motility, so increased risk of aspiration. We always consider these patients as full stomach. There's a decreased ring barrier pressure, and acid prophylaxis. RSI is mandatory after 18 weeks of gestation. When we talk of the kidneys, there's increased renal plasma flow, increased GFR. So that means that even if the urea and creatinine are normal, that means that the renal function has already been impaired to a certain extent. Also, because of the decreased reabsorptive capacity, there's glycosuria and proteinuria in these patients. So again, you have to be mindful of these things. So why are so we worried about giving anesthesia to these pregnant patients? Number one, all the physiological changes that we have discussed till now, ranging from the CNS to the hematological, to the GI systems, respiratory, cardiovascular, renal, all these things will make things tough for you. You have to calculate dosages. Remember, any drug that you give, the pregnant woman is much more sensitive to those drugs, and you have to reduce dosages. Main concern about anesthesia to a pregnant female are the fetal concerns. Number one, in the early phases of pregnancy, when there is organogenesis, there's an increased risk of miscarriages. It is 10.5% in the first trimester, and it is maximum 7 days after surgery. So you might have gotten a surgery done and all, and the patient miscarriages after 7 days. So all the rest, the concerns to the mother and the baby have to be explained to the patient and the relatives before taking up for surgery. These babies might be small for gestational age because of exposure to the anesthetic drugs. Preterm labor, maximum chances in the third trimester, 82%, and in the second trimester, it is 16%. And preterm delivery, when full term, the chances are 16%. And also, there's always a risk of teratogenicity to the growing fetus by the anesthesia drugs. Now, the neurodevelopmental changes, this is a bit of a, what we say, it's a gray area. There were reports that the inhalational agents and the drugs that we use and the baby is exposed to these inhalational agents, there is a slight behavioral and intelligence problems and developmental problems in the child later on. But then these things have been debated now. But if a surgery is due, please do not deny anesthesia to these patients. So yes, we have to keep the dosage to the minimum, but then we don't have to keep the patient awake just because we are worried about the neurodevelopmental changes. And although there's still a controversy ranging on it, now it has been said that these changes, these babies might take a year or two catch up to their normal counterparts. And also, it may be so because there is a high risk of preterm labor and preterm delivery in these patients. So most of the babies that are born are premature and small for gestational age. So their development, in any case, is lagging behind that those of the normal babies, and maybe there is no direct effect of the inhalation on the developing brain. So we are still finding it out. The research is still on, and this is still a gray area where we cannot give a definitive answer to this question. Now, talking of the teratogenicity, we know that the WHO classifies as the drugs as A, B, C, D, and X. A is no fetal risk in control studies. B is no risk to human fetus despite possible animal risk. So animal risk might be there, but human fetus it is not found, or we are not sure. C, we are definitely not sure whether it is safe or not. D, we are definitely sure that this is there is an evident risk to the human fetus. And X, we know that it is causing a risk, and we are not supposed to use it, such as chloramphenicol. No, again, WHO has revised this and FDA has revised this. They don't no longer use the ABCDX system. They have used a new grade methodology, and that should be followed. This has come out very recently, and that should be followed. So, most of our drugs, anesthesia drugs that you see, are in the category of B and C. So, A and B are absolutely safe. D, better to avoid. C, you are not sure whether they'll cause a risk or not. So if we see here, benzodiazepines are to be avoided, nitrous oxide is to be better avoided. Local anesthetics, B or C, most of the analgesia anesthetics are in the C category. But then if you're using ketamine is safe, propofol is safe, sevoflurane is safe, so that goes for general anesthesia. When you're talking of local anesthetics, lignocaine and ropivacaine is better. Better to avoid opioids and NMBAs. If you want to use something, cisatracurium is better than other NMBAs. So that is in a nutshell. Now, what are the fetal concerns? Why are we be so worried about the fetus? So the main aim is to maintain the uteroplacental perfusion. Or what the baby wants is just its regular supply of nutrients via the uteroplacental blood flow. So any hypoxia or hypercapnia in the mother will lead to vasoconstriction, decreased perfusion through the uteroplacental bed, resulting in acidosis and death of the fetus. So hypoxia and hypercapnia are to be avoided and remember the range because decrease uterine blood flow, ODC shifts to the left, and decrease oxygen delivery to the fetus. So hypercapnia and hypocapnia both are bad. When we have induced general anesthesia and we are initiating positive pressure ventilation, one is hypocapnia, we have already said, decreases the uterine blood flow. It also increases the intrathoracic pressure. Now, what will happen to the intrathoracic pressure? It will be decreased because of increase in intrathoracic pressure. There will be decrease in its return, low stroke volume, and ultimately it lead to a decrease in uterine flow. And that is the reason why left lateral tilt is to be maintained so as to improve or maintain the venous return to the heart so that the uterine blood flow does not decrease. Uterine hypertonia. So there, if because of the increased uterine vascular resistance, there might be decrease in uterine blood flow. So while the baby is there, it is better to have a relaxed uterus to improve the uteroplacental perfusion. So now let us take some case scenarios. Case one, it's a 24-year-old primey with 6 weeks of menorrhea. Remember, organogenesis is just going there, going on. She complains of pain abdomen. So it's an acute attack. McBurney's point tenderness is positive, so the diagnosis is acute appendicitis, and the patient does not have any other comorbidities. So now this patient has presented to the casualty with these signs and symptoms. So this is one case, early pregnancy presenting with acute appendicitis. Just keep it in your mind. Case two, again a young primate, in early pregnancy, pain abdomen. There is a USG which is suggestive of a large ovarian cyst, which is benign. She has been diagnosed. It's a large ovarian cyst, which appears to be benign, and the surgeon says, I want to do a lap cystectomy, and there are no other comorbidities. Case 1, early pregnancy with acute appendicitis. Case 2, early pregnancy with large ovarian cyst and a cervical pain abdomen. Case 3, okay, now this is 30 weeks in. So this is the third trimester. Patient is now presenting in third trimester with pain, fever, vomiting, diagnosed as acute cholecystitis, and the surgeons want to take the patient for lap cholecystectomy. So now we have three patients, two in early pregnancy, one in third trimester, one is an acute appendicitis and obvious emergency, one is a benign cyst, and third one is a acute cholecystitis, some of sort of a semi-emergency but recent onset. So how do we decide whether we have to take up the patients immediately or not, or what are the risk benefits associated with taking up of each of these cases? So this is the decision tree in a pregnant surgical patient. This is how we decide whether to take up the patient or not. Now, pregnant surgical patient, right? If it is an emergency surgery, if it is an emergency surgery, you do not think of anything else. You proceed with optimal anesthetic for mother, modified by considerations for maternal physiological changes and fetal well-being. The perinatologist and obstetrician should be present, and intraoperative and postoperative fetal and uterine monitoring may be useful if the baby is not delivered, or you need not have to deliver the baby intraoperative. Okay, so emergency surgery, do not think anything. You have to go in for surgery then and there only. Now coming for the elective surgery. If it is an elective, purely elective surgery, you delay until postpartum. Obviously, you need not take up the surgery. It can be done at a later date. It is not causing any harm to the mother as such or to the fetus. So we can postpone it to after delivery. Essential surgery. Now, this is where it is tricky. It is neither emergent nor it is elective, but it is better if it is done in the interest of the mother. So, if it is the first trimester where the organogenesis is happening, so if there is no or minimal increased risk to the mother, you may postpone it to second trimester. That means that if the surgery can be postponed without affecting the pregnancy, you can postpone it to the second trimester. But yes, if you require to get the surgery done, then it has to be taken up immediately, right? So if there's a risk to the mother, you have to proceed with the surgery. But yes, if the disease can continue for some time, you can maintain the disease medically, it is not causing much of a problem, the third trimester. The message is, do not delay indicated surgery irrespective of the gestation. So it is just that you have to modify, you have to explain the risk and benefit to the mother, and you might have to modify your anesthetic and surgical technique so as to provide the maximum benefit to the mother and the fetus. So coming to the case, 24-year-old preemie with 6 weeks of amenorrhea. It was an acute appendicitis. So what kind of a surgery is this? This is an emergency surgery, and if it is not a lab and I want to avoid GA, I would get it done at a regional and have a neonatologist. I'll have an obstetrician, not a neonatologist, rather. I'll have an obstetrician on standby if possible. Now, in this case, fetal monitoring is not possible. So, but I'll have an obstetrician on standby for any abortion or expulsion of the products. But yes, and then monitor the patient. This is an emergency surgery. I'll go and I'll talk to the surgeon that instead of taking it for laparoscopically, you please take it under, you do it open appendicectomy, and I'll give regional anesthesia to this particular patient, which will minimize risk to both the mother and the developing fetus. The second case, 20-year-old preemie with 8 weeks of amenorrhea, again organogenesis was almost towards completion, but yes, it's still going on. Large ovarian cyst. It's a large ovarian cyst. The mother says, I don't want a scar. It's benign. And the surgeon says, okay, it'll be better if I perform a laparoscopy rather than giving a huge abdominal scar to this particular patient. So again, it is an essential surgery. Why? Because it's a large ovarian cyst. as the baby grows, it might lead to torsion, it might lead to hemorrhage. There might be other complications as the pregnancy progresses. And remember, ovarian cysts grow under the influence of hormones. So this is an essential surgery, but yes, it is not urgent right now. So we can probably wait for another 2 months and then do it in the second or third trimester when the organogenesis is complete. So it is an essential surgery and you can postpone it till second trimester. Coming to the third case, 30 weeks amenorrhea. Now this is interesting. It's almost third trimester, acute cholecystitis. It is an essential surgery. And again, since it is in the second or the third trimester, organogenesis is occurred. So I would do it under GA, although there are now some reports which do it under uh, segmental spinal anesthesia, but I would still prefer GA for this particular patient with the baby in situ and the uterus already in the respiratory, already working overboard with the increased demand, and I don't want to further increase the demand of the oxygen demand and work of breathing on the mother by doing it under regional. So I would get it done under general anesthesia, explain the risk benefit, keep a neonatologist and then obstetrician standby. Monitoring again won't be possible in this particular patient, but yes, preoperatively, postoperatively, and then as soon as the surgeons are off the patient, I would like to monitor the patient, with the baby, and then decide and continue with the pregnancy. Case 4. 28-year-old G2P1L1 with incidental UPT positive or any trimester with a burn contracture. Now, this is a purely elective surgery. Even if it's first trimester, second trimester, third trimester, this surgery can be done after delivery. So why get it done during the pregnancy period? We just postpone it and we do it once the baby has been delivered. Purely elective surgery. So now, these patients have come for surgery, and how do we manage them? Very operative. Like all cases, preoperative period, excellent history, head to toe physical examination, including the obstetric examination, and document the obstetric examination. That is very important, including the vitals of the fetus. Investigations. CBC to look for anemia, thrombocytopenia, dilution thrombocytopenia, as I said. KFT, creatinine, BUN. Remember, normal values indicate that there is some amount of injury which is going on. Proteinuria, again, if it's later towards more than second trimester, after 20 weeks of pregnancy, you might, if you find significant proteinuria, that might be indicating trend towards preeclampsia, eclampsia. LFT, right? So the bilirubin is normally decreased and serum alkaline phosphatase is normally increased. TSH. Now remember, whenever we get a TSH done, the normal range ranges from 2.5 to 5.5. But in pregnancy, the range decreases. So anything more than 3 is a decreased TSH and the patient may be okay. And radiology, X-rays, CTs for diagnosis. Remember, less than 50 milli GY or 5 rads are safe, and not to exceed 100 milli GY. So that is the dictum for radiology. Now this is the table which gives you the milli gyridos for the fetus. And remember, we are not supposed to cross 100 during the entire pregnancy. So a chest X-ray is relatively safe. Abdominal X-ray much more testing, and a chest X-ray can be done with an abdominal shield to further shield the fetus from the radiation. MRI, if you can get it done, it is the safest. There is no radiation at all. Ultrasound is absolutely safe in pregnancy. So we obtain a written informed consent after counseling. There's always a risk of fetal loss, so this has to be explained just to the fetus, and you might require a cesarean delivery for fetal indication, intraoperatively, postoperatively, also if the fetus is obviously viable. So these things have to be informed and taken in writing from the patient and their relatives. You have to reassure the patient acid reflux prophylaxis is a must because these patients are at an increased risk of regurgitation and aspiration. You always provide a left uterine displacement after 16 weeks. Regional is obviously preferred over general anesthesia and it will depend again on the surgery that you are undertaking the patient for. Pre and post-operative USG and fetal heart rate monitoring is a must, and variability is evident after 24 weeks of gestation. You have to keep in mind. Steroid for lung maturity and tocolysis. Usually, we prefer this after 25 weeks of pregnancy, but remember the steroid for lung maturity requires at least 2 doses, 24 hours apart, so that will be 48 hours. And tocolysis, general anesthesia in itself is a tocolytic. So again, there's a gray area here, and you have to go on the advice of the obstetrician. Wherever you're doing this particular surgery in a pregnant woman, obstetric and neonatal facility should be available. Obstetrician and the neonatologist should be on standby as if the baby is viable, if the fetus is viable, and there should be a facility for an emergency facility as well in gestations about 26 weeks. If the anesthetic considerations is avoid hypoxia, hypercapnia, hypocapnia, hypertension, metabolic acidosis, and hypothermia and hyperthermia, which we anyways do for all these cases. But yes, the implications of these particular complications. Remember, you are catering for two lives. It is not only the mother, it is the fetus also that you have to protect. And although these might be well known by the mother, these things may not be well known by the fetus. So all these things have to be avoided, and a homeostasis have to be maintained for the mother. Only then the fetus will be homeostatic. Routine ASA monitors, no additional monitors required. FHR not routinely required, and it may not be possible always to FHR. Always considered as full stomach, so we have to go in for an RSI or a modified RSI. The role of ketamine, again, ketamine, although indicated for RSI, can be used, but then it does increase the intragastric pressure, may cause regurgitation, vomiting. So you have to be careful with ketamine. Although personally, I feel ketamine is a wonderful drug in these patients because you'll by giving ketamine, you'll minimize the induction agent. Benzodiazepine is not required. Opioid is not required. So many other drugs are obviated, and you require much less inhalational also. So ketamine, I feel again there's a gray area, but yes, it does increase the intragastric pressure. Analgesia wherever possible. Please use regional anesthesia, facial plane blocks, epidural, any other regional block. Opioids are to be minimized but not withheld. Remember, you have to give adequate analgesia. If opioids are required, please do not shy away from giving opioids. But yes, the obstetrician and the neonatologist have to be informed. Obviously, we have to go in for a multimodal analgesia. PCM is absolutely safe. NSAIDs we tend to avoid towards the later pregnancy because the increased incidence of patent arteriosus. So yes, but all other options we can safely provide. Uh, Maintenance is by inhalational TIVA opioid-free anesthesia as per the preference of the attending anesthesiologist. Reversal, they say that we do not want too much of a hemodynamic instability, glycopyrrolate mean, nausea, vomiting, tachycardia, hypertension, all those things. So Sugammadex can be used, but then it binds progesterone as well. So remember that if you're using Sugammadex, it will bind progesterone and may result in front-end progesterone deficiency in certain patients. So again, Sugammadex is not very well studied in pregnant patients for reversal of neuromuscular blockade. Post-operatively, analgesia, thromboprophylaxis, and remember, whatever drugs that you give are excreted in the milk, so you have to be careful because whatever the drugs that the mother is taking, the baby will inadvertently get it. So coming to the drugs, post-operative drugs, paracetamol is absolutely safe, process the placenta, brufen C, grade C, again, ductus arteriosus, diclofenac, appears to be safe, but then ductus arteriosus, codeine, morphine, tramadol, again for intraoperative this thing, human data is lacking. But then remember, all these drugs are excreted in the milk. So you have to consider these when you're giving anesthesia to the the post-operative pregnancy. Right? So coming to the special cases, laparoscopy is now considered safe. Preferred time is obviously second trimester, but as I said, you can perform any surgery anytime during the pregnancy, preferably to keep the intra-abdominal pressure less than 10, definitely not more than 12. We do an open technique for a port insertion rather than a blind, so as to not injure the uterus. We have to position the patient gradually because of the uh, risk of hypertension. So we have to make gradual position changes. ETCO levels have to be maintained, and if possible, we monitor the FHR and the uterine tone during lapse. That may not be always possible. Cardiac surgeries require high pump flows, 30 to 50% increase over the non-pregnant state, keeping in view with the increased blood flow. Mean arterial pressure should be more than 65 mmHg, again to maintain the uteroplacental perfusion. Hematocrit more than 28%. Hypothermia, again, we limit it to less than 32 degrees, not less than 32 degrees centigrade, and we have to monitor the fetal content. Patients optimate acid-base, glucose, PO2, and PSO2 as we complete other surgeries as well. So exit is a specific procedure which is performed at the time of cesarean delivery, and it is usually for airway-related fetal malformation. It is a topic in itself, so I'm not going into much detail. For this, GA is usually preferred, although there are case reports where spinal anesthesia has been given during exit procedure only, but then you require an infusion of nitroglycerine so as to maintain the uteroplacental flow and to relax the uterus. So, tocolysis, as I said, high doses of magnesium sulfate and tocolysis is mandatory for exit. So as to for the baby to come out and the placenta is not separated from the uterus till the airway of the baby is secured. Until that time, it's just like placing the baby on a cardiopulmonary bypass using the placenta. So that is the exit procedure, that you take the baby out of the womb, but you're maintaining the cardiorespiratory function of the baby by the uteroplacental blood flow. And definitely to intubate the fetus, you have to give analgesia and maybe muscle relaxants for that. And as I said earlier, uteroplacental flow is to be maintained till fetal airway is secure. So the key points of today's presentation are: you have to avoid or minimize aortic cable compression. Wherever possible, perform the surgery in the second trimester. But yes, the gestational age is not important whenever you are considering surgery in a pregnancy, except for elective surgery where it should be postponed till delivery. Regional anesthesia wherever possible, and in combination with general anesthesia so as to decrease the requirement of drugs in general anesthesia. Maintain a normal maternal physiology. The main thing is emphasizing it again. Please maintain uteroplacental perfusion and avoid fetal asphyxia. Drugs have to be chosen such as to minimize their effects on the fetus, and the anesthetic agents that we use in clinical dosages have been found to be safe without any teratogenic efforts. Thank you. So I'm open to questions. Over to you, please.
Thank you so much, sir, for your wonderful presentation. So we do have some questions we'd like to take up.
Yeah, sure.
So, sir, the first question is, what are the safest anesthesia options for pregnant patient undergoing non-obstetric surgery?
So as I said, that will depend on the surgery that you're performing. But yes, regional anesthesia appears to be safe and much more because you're limiting the amount of drugs, you're limiting the exposure to the fetus. But then with the regional anesthesia, if you're causing hypertension and other complications, then it is also not safe. So it is not the type of anesthesia, it is how you manage your anesthesia that.
Thank you, sir. The next question is, How do you minimize the risk of anesthesia to the fetus while ensuring adequate pain control for the mother?
So as I said, that is where the skill of the anesthesiologist come in. You have to maintain the mental and physiology. If you maintain the mental and physiology, and if you're mindful of the drugs, the effect of the drugs that is going to have on the fetus, you'll obviously maintain all these things. So there is no one right answer for that. That will depend on the drugs that you're using, the dosages that you're using, and how well you are maintaining your maternal physiology.
There is one last question, sir. What are the recommended strategies for maternal fetal monitoring during and after non obstetric surgery?
See, for maternal, we just going for the ASA monitors, ASA recommended monitors. But for fetal, yes, during surgery, it might not be possible to monitor the fetus, but yes, we do document the fetal well-being before the surgery and after the surgery. So we do a CTG, we do a fetal heart rate monitoring, and we do an ultrasound. So these are the things, and based on the post-operative monitoring, you might have to do it 6 hourly, 12 hourly, or 24 hourly, depending on the presentation of the fetus. If the fetus is well and healthy, initially you might do it for every 6 hourly, and then if the baby is fine, then you can increase the intervals to 12 hourly and 24 hourly. Now, if the baby has taken a hit, then obviously you might have to do a continuous monitoring, and you might even have to delay if required.
Thank you so much, sir, for answering all our questions, and that's all from our audience. Sir, before concluding, any last remarks from you?
So, as I said, remember there's no right or wrong in anesthesia. It is how you use your techniques. You have to maintain the normal physiology or the existing condition of the patient and better it. So, that is what you have all the drugs at your disposal. You have to use them wisely. There's no one right or one wrong answer in this particular. So, that will come with experience and guidance from your seniors and your colleagues. Thank you.
Thank you so much, sir, for joining us today and enlightening us with this wonderful topic. And thank you once again.
Thank you.